Hello everyone. In this session we are taking you through what we are calling semen analysis, or you can call it sperm analysis, the test which is being performed to rule out male infertility. So one of the significances is to rule out male infertility, and we are going to see the significance, the composition of semen. Then we shall look at how do we collect a sample from a male who is suspected to have either infertility or after vasectomy. Then we shall talk about how we examine. That is macroscopy. We're going to look at the biochemical tests. Then we shall end with what we call the microscopy. So as we start, please, if it is your first time, remember to subscribe, like the video, and share to many others. So with the semen analysis, what is semen? Semen is a semi-solid substance. It is always grayish-white or pulsant, and it contains what we call spermatozoa, or you can call them sperms. It contains sperms, that is like approximately 5%, then greater than 90% is secretory fluid. And this secretory fluid comes from what we call the prostate gland, the seminal vesicle, and the Cowper's gland. So those glands are the ones that give us these fluid secretions, and these fluid secretions contain different substances like fructose, which gives energy for the sperm to swim. And this fructose is majorly coming from the seminal vesicle. It contains some enzyme like proteases, which enables the liquefaction of the sperm, because after ejaculation, the semen should be liquefied. And what happens, or what enables the liquefaction, are the proteases which are present in this fluid. And it contains also other nutrients like vitamin B12, then the proteins which we have seen, and the carbohydrate where we have seen fructose. And we are saying that greater than 90% of semen is the secretory fluid. And these sperms which we are saying they cover 5%, they are produced from the epididymis. Epidermis. That's where they are produced from. So after seeing some of the composition of semen, what could be the significance when the doctor requests for semen analysis? One of the purposes is the doctor can request for the sperm analysis or semen analysis for diagnosis of infertility. If we want to rule out male infertility, maybe after marriage, it is 1 year, 2 years, you're not pregnanting your woman, and maybe after the lady has done all the scan and all hormonal tests, they are normal, we can request the male to bring sperms to assess the quality and motility and other things which can cause infertility. And this semen analysis to rule out infertility, it is done alongside with other tests like luteinizing hormone, like follicle stimulating hormone, and testosterone. So under endocrinology, we also have to do alongside with other hormones like luteinizing hormone, follicle stimulating hormone, and testosterone. These ones should be done to accompany the semen analysis. Another significance is for prognosis. That is monitoring. Maybe after doing semen analysis, we find out that the patient has low sperm count. So if the doctor is going to give treatment, then after the treatment, this patient has to come back and we check if the sperm number is increasing or if the patient is responding to treatment, what we are calling for prognosis, that is monitoring. Then lastly, we can do it as post-vasectomy. So 1 week or to 1 month after vasectomy, that is cutting of the glands of the male, as a way of family planning. So to see if it was successful, after 1 week we can do semen analysis to check if there is presence of sperms. And if we see sperms, it means it was not successful. Then azoospermia shows up, absence of sperms will show you that the vasectomy procedure was successful. So this is some of the significances why we can carry out semen analysis. So the next thing we're going to look at is how do we correct the specimen from the patient? The patient has come, which instructions do we give and how do we correct? First of all, when the patient comes, you prepare them by making sure they have abstained for 2 to 7 days. So these 2 to 7 days, they must have abstained from sex or from any ejaculation. That is so that to allow enough maximum number of sperms in the semen. So the abstinence time is 2 to 7 days. Then after 2 to 7 days, you're going to give instructions on how the patient is going to correct. And these instructions should be both oral and written, so that the patient is able to understand very well how to correct this semen sample. You're going to provide with a sterile, wide-mouthed container. After giving instructions on how to correct, and what are the methods we can use? We can collect. The most preferred is masturbation. Masturbation is the most preferred, whereby after giving instructions on how to correct, the patient to make sure has put all the portion, you give a sterile wide mouth container and provide a suitable room, or what we can call a room away from any disturbance around the clinic, and instruct the male to masturbate so that we can produce semen. Though according to WHO, it shows that masturbation, the quality of the sperms by masturbation are not so much motile compared to by normal sexual intercourse. But the preferred method remains masturbation. But due to religious beliefs, the males who cannot accept masturbation or who cannot manage, you can provide with them another method whereby they use non-latex. They can use non-latex condoms. These ones are commercially prepared and they are free from lubricants. They don't contain, there is no lubricant which can be toxic to the sperms. So in case masturbation, which is preferred, the patient is not able, you can give a non-latex condom and you instruct the male to put it on before sexual intercourse. Then during sexual intercourse after ejaculation, you instruct the male to tie this condom, or they can even transfer the fluid into the sterile container and bring it. This sperm which is collected from home must be brought within 1 hour. Within 1 hour after correction. So it must be brought to the lab within 1 hour. And during transportation, we must maintain temperature between 20 to 37 degrees centigrade. So you can instruct the patient to put the sample in the pocket, the sample in the container, so that we keep it warm as possible as 37 degrees centigrade, but must be within 1 hour of correction. So after the patient has corrected this semen sample, they must This container should have been labeled with the name, the identification number, the age of the patient, then plus the method they are going to use, and the time of correction must be noted. And in any case of anything or any loss of a portion should also be noted, and also we note the time of abstinence. Are they 2 days? Are they 3 days? Are they 4 days? Or 5? It is also noted to help us during interpretation of results. So this is how we can correct the semen analysis. I want you to note that coitus interruptus, what we call withdrawal method, is not preferred or should not be used because many times we lose the first portion of the sample. And this first portion contains a large number of spermatozoa. So coitus interruptus, what we are calling withdrawal, should not be used to correct semen analysis. Other methods we can use for those with spinal injury, we can use the penis vibrator, which can enable them to ejaculate. Or we can even extract sperm by surgery. Those who are unable to do these two methods, but the most preferred is masturbation, followed by using non-latex condoms. So after seeing on how we can correct, and should be reached in the lab within 1 hour, and should be transported at this temperature. Now let us look at how can we examine. So now we are going to look at laboratory examination. How do we examination of sperm when they reach in the lab? How do we examine them? We begin with what we call macroscopic. And under macro, here you're going to use your eyes to see what could be the problem with the sperms. And the first thing we do is appearance. We can look at the appearance. Physical appearance of the semen. It should be grayish white. Grayish white or pearlescent. So it should be opaque. And another thing, it should be homogeneous. So it should be homogeneous, grayish white or pearlescent. Or what we can call, it should be semi-solid if it has not liquefied. That is the physical appearance or the normal appearance of the semen. Grayish white or pearlescent, and should be homogeneous. But in case of different color, for example, if the semen is yellow, we can suspect like maybe liver disease, which is causing jaundice, or we can suspect a patient to be on certain food or medication, which is triggering the semen to look yellow. And when the semen are red or pink, we can suspect hemospermia. And this hemospermia can be caused by like severe UTI within the ducts, which is causing the blood to appear in the semen. Or it can be even prostate hyperplasia or cancer or an infection that can cause blood to appear in sperms. Then another thing after appearance we can talk about is the liquefaction time. Liquefaction time. The time taken for this semi-solid substance or coagulum to liquefy either at room temperature or at 37 degrees centigrade. As we say, there is presence of proteases that enable it to become a homogeneous liquid. And the normal liquefaction time should be between 15 to 30 minutes. So within 30 minutes, this semen should liquefy. But in case it does not, we wait for 1 hour. But beyond a liquefaction time greater than 60 minutes, which is 1 hour, that is abnormal. That is abnormal. So liquefaction time should be between 15 to 30 minutes. The time taken for the semen coagulum to liquefy and become homogeneous. Another thing we shall look at is the volume of the semen. And this volume, how do we measure? We measure using calibrated tubes. These calibrated tubes are labeled in mils, so we can easily read off the volume, and the volume, the normal one, should be between 1.5 to 5 mils. So the least should be 1.5 mils. That is about the volume. So apart from measuring using a calibrated cylinder or tube, you can also use weighing scale, whereby before you give this empty container to the patient, you first weigh it on a weighing scale, you record the grams, then when they bring it with the semen, you weigh again in grams. Then you use the formula whereby volume is equal to mass divided by density, whereby density of sperm is always between 1.025 to 1.125. So you can easily use weight, whereby volume is equal to mass over density, and this is the density. So those are the two methods you can use to determine volume: measuring from calibrated tubes, or by measuring the weight of the empty and the weight with the container with the semen, and you use the formula volume equaling to mass over density. And this is the reference range. The last one under macroscopy is the viscosity. So we can also measure what we call viscosity of the sperm. And as we know that sperm, when they are collected, they are viscous, they should be viscous. And how do we determine viscosity? Is we get a pasture pipette. And this pasture pipette, we make it touch in a container containing semen. So when we pipette this semen, when we are dispensing, it should be in discrete drops. It should not make, if this is a dropper, the semen, which is the normal one, should be in discrete drops to the container. But in case it makes a thread greater than 2 centimeters, that one means the sperm is hyperviscous. And hyperviscosity can be also a condition which might be causing infertility, whereby there is no presence of the proteases to liquefy the sample so that it becomes less viscous to enable the sperms to swim within the female reproductive system. So hyperviscosity is seen by when I'm dispensing the sperm from the pipette, making a thread greater than 2 centimeters. That one is hyperviscous. So those are the ones we can talk under macroscopy. Then under biochemical, we have tests like pH, whereby we use a pH of narrow scale between 6 to 10, and the normal range for the pH should be 7.2 to 8.0. So if the semen pH is too alkaline, it can imply presence of infection. Then if it is too acidic, it means there is much secretion from the prostate. And this one can affect the quality of the sperms. But the normal should be between 7.2 to 8.0. Another thing we can use is fructose test. As we have seen, this fructose is a monosaccharide produced from the seminal vesicle, and it is the one that provides energy for the sperm to swim. And this fructose can be tested by a test known as Seliwanoff's test. It is a biochemical test. And this cell-1-offs, we use cell-1-offs reagent, which contains conch, hydrochloric acid, and resorcinol. And if we add it to semen, we look for pink red color. So presence of pink red color, after heating, we apply heat. We get semen, those are 2.5 mils. Then we add 0.5 mils of the cell-1-offs. Then we heat or boil as we observe for the presence, for the formation of the pink red color, indicating that fructose is present. If there is no pink red color formed, it means the fructose is absent and can also be one of the causes why sperms cannot swim up to the oviduct. That is the biochemical tests. After looking at the macroscope, biochemical, now let us look at the microscope. These are tests which we can do by examining under a microscope. We cannot see this by our naked eyes. And one of them is sperm motility. We want to see if the quality of your sperms are able to move or to swim towards the oviduct. And we measure it whereby we make a wet preparation. How do we make a wet preparation? And this microscopic test should be done within 30 minutes. Because within 30 minutes, sperms are able to still move, to still swim very well. So we make a wet prep, whereby after the sample has liquefied, we mix it well and get a microscope slide and put a drop. We put a drop of well mixed semen, then we apply a cover slip. Then we examine using times 10 and times 40 objective. In case the semen has not liquefied or it has a longer liquefaction time, we can treat it with bromelain, or we can intubate it in an incubator at 37 to enhance liquefaction. Those are the two ways. Bromelain is a proteolytic. It can help us to coagulate the coagulant, or we can intubate at 37 to ease liquefaction. And when it has liquefied, before we make a wet prep, we mix it well homogeneously, then we put a drop and apply a cover slip, and we examine using these objectives. What are we examining? We report in 3 different ways. We look for the sperms which we look for progressive motility. Progressive motility, which we abbreviate as PR. Then we look for those which are non-progressive. Non-progressive motility. They are moving but not making. So you find non-progressive motility sperms, they only move around the place where they are. They don't make a forward movement. You find the sperm is swimming but remaining in one position. So they are motile but non-progressive. Whereas those which are progressive, they are moving from one place to the another, either forward movement in a straight direction, or they can be moving around, but so long as they are making a progress in their movement. Then there is also another category for those which are immotile or non-immotile, which this one we abbreviate it as NP, this one is IM. So these are the 2 ways we can report motility under semen analysis. And the normal range for those which are progressive should be greater than 32% according to WHO 5th edition. Then if I get the sum, if I want to get total motile sperms, I get those which are progressive plus those which are non-progressive. I'm able to get the total motility. And the range should be greater than 40%. though some books give greater than 60. But WHO 5th edition recommends 40%. That if you have 100% sperms, 40% should be motile for you to be fertile. And how do we do it? This wet prep is done in a replicate. You make 2 preparations. And after making 2 preparations, you make sure you count at least 200 spermatozoas. You must count 200 spermatozoas and you express it in percentage. But it is done in replicate. So you do 2 of them, then obtain the average. Obtain the average so that you quality control. In case the first 2 replicate, the results do not agree. You find the difference is greater than 10 among the 2 replicates you have done at first. You have to discard those results and repeat again, mix, and then do other 2. That is in case they are not acceptable, whereby the difference between the 2 readings are greater than 10 sperms. They should be within less than 10. So if they are more than 10, between the 2 readings you have made, you repeat. You don't consider those results. Then when they agree, you get what we call the average, and then you determine the percentage. And a minimum of 200 spermatozoa should be read in each replicate. Then you express them in percentage. That is what we can look at under sperm motility. We are saying greater than 40% should be motile. But when we do motility testing, we find that greater than 40, if greater than 40 sperms are immotile, then we continue to what we call sperm vitality, or you can call it viability test. We want to see these sperms which are not able to express motility. Are they live or dead? And that's why we do what we call sperm vitality. We want to see those which are dead. Are they dead? That's why they are not moving. Or they are alive, but due to other abnormalities, they are not able to move. And what we do under vitality, we use a reagent known as eosin, nigrosin, whereby 0.5% eosin is used to stain the head of the sperm, because it contains the nucleus, so it is able to stain it pink. Whereas nigrosin is to provide background staining. Provides background staining for easy visibility of the sperm heads after staining. Still, the test should be done 30 minutes after sperm correction, within 30 minutes. And the test should be done still in replicate, whereby you're going to make 2 preparations. And how do we make them? We first mix a liquefied sample homogeneously. After mixing, we have 2 slides. And these 2 slides, we are going to put a well-mixed semen. Then we add eosin, which is always red in color. We add eosin. Then we also add nigrosin. Nigrosin is enable to provide background staining on which we can visualize it. We can visualize stained heads. So after this, we apply a cover slip and we examine this wet preparation. So you mix all of them. Equal volumes, we use equal volumes of the sample and the reagent. And we are saying that because eosin is able to stain heads, this one is under ability of this stain to penetrate dead sperms. So only dead sperms will be able to be stained. So for example, if I have here some spermatozoa with the midpiece, then the tail, I have another spermatozoa with the midpiece and the tail, I have another spermatozoa. So the ones which are dead, if we have some sperms which are dead, they are going to take up, their heads are going to take up the pink color of the eosine. So if those ones which take up the pink color, it means these ones are dead. Then the live ones, if I have another spermatozoa here, the ones which remain colorless after staining, these ones, they are live. So these two are live sperms. Why? They have not taken up the eosine stain, but the background is stained by nigrosin. That is what we do. So that is how we can determine sperm vitality. And according to the reference range, viable sperms, according to WHO 5th edition, viable sperms should be greater than 58%. Though other literature gives greater than 75% of the sperms should be viable. But according to WHO 5th edition, tells us that it should be greater than 58% for you to be fertile. So in fertile people, you find they have less than 58 viable sperms after staining with eosine. In case you don't have eosine, we can use what we call hypoosmotic swelling test, whereby we put these sperms in what we call hypotonic solution. So when you put sperms in hypotonic solution, only live ones will be able to swell, and dead ones will not be able to swell after putting them in hypotonic solution. And the swelling of the tail is seen by either coiling or swelling. So the swelling can be seen by coiling of the... So this is the second method. This one was the first method using eosine and nigrosin, but in case you don't have them, you can use hypoosmotic swelling test, whereby you put the sperm in hypotonic solution and you observe the swelling of the heads, of the tail. If there is a swelling of the tail, it means those are live. No swelling, those are dead. And that's how you can be able to distinguish them. So after looking at the vitality testing, C is what we are calling sperm count. And here, we want to count how many sperms does this patient have, because sperm count is very essential. And we use a counting chamber known as improved Nuba. So here we are using improved Nuba counting chamber. It's the one who you can call it hemocytometer, whereby when we apply a cover slip, it leaves a depth of 0.1. So its depth is 0.1 millimeter. So the counting area is on this trough. That's where we count the cells after applying the sample. So this space, this is where we find the sample in this counting chamber. But before loading the sample, we first mix it 1:20 with formalin. This formalin, we can use 10% formalin containing sodium carbonate. So this is the diluting fluid we are using, and we are using the dilution factor of 1:20. What does it mean? You're going to get, if this is the tube, you're going to add 1 ml of well-mixed semen, 1 ml, up to 1 ml mark. Then you add sodium carbonate formalin up to 20 mmol. So you add the formalin, then afterwards you mix. After mixing, you mix several times. Then after mixing, you come and apply a cover slip on the counting chamber. After applying a cover slip until Newton's ring appear, you come and load the well-mixed diluted sample into this counting chamber. Then after putting the sample, you mount it on a microscope stage and wait for 3 to 5 minutes for the cells to settle. After these minutes, you are able to examine using 40 times and 100 times objective. These are the ones we use. We don't use 100, we use 10 times and 40 times objective to count the number of sperms within the counting chamber. And there are two methods we can use. One, we can decide to count in 2 large squares, any 2 large squares. And when we count in 2 large squares, so we have 9 large squares, 1, 2, 3, 4, 5, 6, 7, 8, and 9. So we can choose this one and this one. So we count in the 2 large squares. Then the total number we get the number of sperms counted, we multiply by 100,000. This is one method. And this one will be in per mil. This one shall be our sperm count or sperm concentration. Then to get the total sperm count, you get the sperm concentration times the number of mils which you measured under volume. If you measured 5 mils, the answer here you get, to get the total sperm count, you get the result here, you multiply by the volume, which can be 5 for our example. So there is a difference between sperm concentration and total sperm count. Sperm concentration or sperm count is the number of sperms in 1 mil, because we use 1 mil. But the total sperm count per ejaculate is the sperm count or sperm concentration per mil multiplied by the total number of mils. Then that one will be the total sperm count per ejaculate. That is what we are trying to mean. So if you don't want to use 2 large squares, and everything should be done in replicate, after counting 2 large squares, you can also choose others. Then you get the average. And in case the 2 countings do not agree, you make another preparation until they agree, and then you obtain the average. The reference range should be greater than 20 million sperms. That is 20 times 10 power 6. This is per mil. Or it should be greater than 39 times 10 to power 6 per ejaculate. That is the total sperm count. But the sperm concentration, this is the range, but the total, according to WHA, is 39 million sperms per ejaculate. That is after multiplying with the total volume. You can ask yourself, in case we don't count in 2 large squares, which other method can we use? Another method we can use, we can decide to count in the 4 corner squares. We can choose to count here. We count these 4 corner squares plus the 1 central square. And we know the corner square has 16 small squares, whereas the central has 25 small squares. So if I count in the 4 corner squares and the 1 central square, the formula changes. The formula now will be, if I use the 5 squares, the formula will be number counted times 1 million. That is times 10 power 6. That is per mil. So if you use two large squares, you multiply the result by 100. But if I use these two small, the 4 corner squares and the 1 central square, I am able to multiply by 10 power 6. That is what we can see. So after this, but the simplest is always calculating in 2 large squares. It is always sufficient to give us the real values we need to determine the sperm count, and we have seen the reference range. Though some literature give 15 millions. So you will find when you're reading, some literature gives 15 millions, others give 20 millions. Then WHO per ejaculate gives 39 million sperms. So lastly, we want to look at the morphology. That is ruling out abnormality, or those which are abnormal, the sperms that might be abnormal. And how do we do this? The morphology, it is done by making a thin film. We make a thin film or smear using a well-mixed sperms. After mixing them well, make a thin film. If this is a slide, put a drop, and using a cover slip or another slide, make a thin film of the ejaculate. Then this film, you leave it to air dry, but here we don't allow it to air dry. Immediately after making a thin film, you fix it when it is still wet using absolute ethanol. Use absolute ethanol to fix between 5 to 10 minutes. After fixing this smear, we are going to come and after fixing the smear, we are going to use 10% formalin, drop-wise, to remove some bubbles or some mucus. So the formalin enables us to remove the mucus from the thin smear. After treating it with 10% formalin with sodium bicarbonate, which is acting as a buffer, we are going to stain. And how do we stain? We can use this primary stain and as dilute carbofucsin. We dilute it 1:20 and we stain it for 3 minutes. Then after we wash and add a counter stain such as Lofra's methylene blue, we also stain it for 2 minutes. Then after 2 minutes, we wash off the stain, air dry, and then examine. So this is the method we can use to determine the morphology. In case you don't want to use dilute carbofucsin together with Lofra's methylene blue, another alternatives stains we can use is Roman whisker stains like Jimusa or Leishman can be used. Another stain we can use is the PAP stain or H&E. They can also be used. So you can use the Jimusa, you can use the Leishman, you can use the PAP stain and H&E staining. But the most routinely used can either be Roman whisker stains or using dilute carbofucsin together with dilute methylene blue, also diluted 1:20. That is 1 drop of the methylene blue and 19 drops of the diluting fluid, which can be like distilled water you can use to dilute. So after staining and drying, we come and examine under the microscope, looking at the morphology of the sperm. And we are seeing the normal morphology of this sperm should have the tail. There is a tail, presence of a tail. And another thing we are going to see, So we see the tail, we see the midpiece, or what you can call the neck. Then it has also the head. And the head contains the nucleus and the acrosome. This is what we call the acrosome. Acrosome, nucleus, those are contained within the head. Then we have the neck, and the neck or midpiece contains what we call mitochondria, which provides energy for the propulsion of the sperm tail. That is the normal morphology of the sperm. So if you find many sperms are like this, these ones mean they are normal. Then how do we get the abnormal sperms? We look at the head, we look at the midpiece, then we look at the tail. Sperms with two heads, you can find abnormality like sperms with two heads, sperms with large head, and also sperms with small head, or sperms with no acrosome. Those are the abnormalities we can see. Sperms with the two heads, you find a sperm like this. The sperm having two heads, one midpiece and one tail. So this one is an abnormality. Or another sperm, the normal head is like that. You find a sperm with a very big head. Another one with a small head. Those are some of the abnormalities. Then about the midpiece, some can have a large midpiece. You can call it large or big, whereby a normal one should be this, but you find a sperm with a large midpiece and a small tail. A midpiece which is almost bigger than the head. Then you can find other sperms with one head, but with two midpieces, but all of them having one tail. Or you can find a sperm with the head, then with the bent midpiece, then with the tail. So it can be large, it can be bent, it can be double midpiece. Those are some of the abnormalities you're looking under the microscope to rule out under morphology. Then lastly, on the tail, you can find with double tail, sperms with double tail, sperms with the coiled tail, and sperms with short. You find a sperm with a midfield but with a short tail. You can find a sperm with a midpiece, then with coiled tail. You can find a sperm with a midpiece but with two tails. Those are some of the abnormalities you have to rule out under microscopy as you're studying for morphology. And WHO 5th edition that normal sperms should be greater than 4% per mil. That is what they recommend. Though other books can recommend 70%, but this is according to WHO. So, hope you have learned with us, whereby we have discussed different examinations, that is macroscopy, biochemical, microscopy, that is where we have looked at the sperm motility, the sperm vitality, sperm count, and how we can determine morphology of sperms. Thank you so much for learning. Please, if you have enjoyed this session, remember to subscribe if you haven't. Like the video and share to many others. Thank you so much.